information friends. Today's webinar is about IVF with donor eggs for women over 40. The webinar presenter today is Dr. Uljana Dorofeyeva. She's the medical director and fertility specialist at International Fertility Clinics in Ukraine. Dr. Uljana, it's a pleasure to have you here with us tonight. Good evening, and can we start?
Good evening, Dorothy. Yes, we can start. Good evening, everyone. As Dorothy said already, I'm Dr. Uljana, and I'm the reproductive IVF doctor and the medical director of International Clinic, which is located in Ukraine. And the clinic has been opened in 2001. And so far, for 16 years, we are performing a wide range of the IVF-related treatment services, including egg donation and surrogacy for the patients from all over the world. To provide with some figures, I have to say that just for 2016, we performed over 1,000 treatment cycles for patients who need IVF treatments, and more than 50% of those patients were foreign patients who came to Ukraine from 26 countries. And I'm really very thankful for the Egg Donation Friends portal for the opportunity to share our best practice and experience with different treatment options. And I'm very thankful for all of you that you decided to have that hour to spend with us and learn more about the ways of how to successfully get pregnant if you are over 40 now. So we are moving to the presentation, and I would like to start from the facts which plays the crucial role as the predictors of the pregnancy. And we will be starting from the general predictors, not talking just exclusively about the age and the women over 40 and only about egg donation. So we will be talking about the problem in a complex. So the predictive factors are, we can divide them for the negative predictors, such as female age. And here, yes, we can talk specifically for the age level over 40 for women, basal FSH, which is also related to the age often, and the duration of the infertility. But there are also positive predictors, which are the number of the retrieved oocytes and the quality and the number of the created embryos. Because why they are positive predictors? Because independently of the negative predictors of the age, FSH, and duration of infertility, if we are getting the euploid, meaning genetically healthy blastocyst, the statistics is not the statistics which is related to the age, but it's only related to the implantation potential and to the different factors, and we will be talking for them a little bit later. And we also have the factors with no association. This is like a type of the infertility indication and the treatment or the fertilization method. So if taking into the account the facts mentioned above, there are different reasons why women in their age of 40 hasn't got pregnancy until that time. So those factors are, some of those women, they were very focused on the career, and it was the first choice for their way of seeing their life until 40, and only after that they decided to think about the options of the creating families. Some of the women haven't met the right partner until that time, and only later they started to think about again to create the family. Some of those, they really tried hard to get pregnancy before and had many of the negative attempts in their medical story, and it also plays a crucial role, and this is very important to select and to speak with those category of the patient. And the main questions are, how to determine a proper treatment, when should I start, how should I prepare myself, how to choose the right IVF clinic. And of course, the biggest questions are what are the chances if I'm over 40 and how long I will be able to have children, which methods should I use. So we will start from the statistical data, and the statistical data, you know, that we are working based on the Cochrane database, based on the different kind of the analysis, retrospective and the prospective analysis performed. Unfortunately, I'm sure that you cannot see all the figures. I need to tell you that the statistics says that if the woman of the age of 40 has 10 oocytes, so the probability of one live birth is about 30%. But the question is, are we going to have 10 mature oocytes? What would be the quality of the eggs? And if we are really having the option to get 10 and how long it will take us. If this is a woman of the age of 44 years, so the chances for the live birth are 8%. And only if we are talking about the possibility to having live birth for women of 40, about 90%, we need to have about 90 to 100 oocytes. And if we want to have, we will never have 100% or 90% live births for women of 44 years, even if we will have this number of the mature retrieved oocytes. So also this data is analyzed by the different analysis, which include over 18,000 cycles. And for women over 40, the need is again between 90 to 100 oocytes in order to create the live birth or the positive result of the IVF. And the number of the, here the figures even higher. So the number of the oocytes needed is about 250. Of course, this is just a statistical analysis. We are not getting into that figures. Another data, 22 oocytes for the women in the age between 23 to 37 in order to have one live birth. And this is the data from over 23,000 ICSI cycles. But it also increases to the need of over 120 eggs for the women of 43. So all the statistics says that if we are going to use our own oocytes for the patients over 40 years old, we need to have a long treatment story and quite, it will require many actions. It will require probably many IVF stated cycles. It will require different hard points of the IVF treatment. But still we can use some markers in order to understand what would be the probability and what would be the chances. The biomarkers which we can use are hormonal biomarkers, and the main one is the IMH level, functional biomarkers which are not telling us so much, but they are available. This is antral follicle count and the genetic biomarkers as well. So why we are getting such a low quality of the eggs for the older category of the women doing IVF? The crucial factors are the mitochondrial function, which is impaired. We are getting less energy in the oocytes. The granulosa cell number is reduced because of the apoptosis, and the oxidative stress is increased. So this all is playing the crucial role for the probability and the possibility of having euploid healthy embryos for the transfer. And you see on that slide that the number of the euploid embryos is getting down with the age. And the best slide is here in order to, if we are going to analyze all the blastocysts which we've got in the treatment cycles for the women of the different age categories, even the egg donors are going to have 30% of the aneuploid embryos, meaning that if we are getting in the average egg donation full 1 by 1 cycle, 6 blastocysts, so 30% of those would be aneuploid. But by transferring 1 by 1 or by transferring 2 blastocysts in one case, we are increasing our chances and the cumulative percentage will be really very, very high. But if we are talking about the regular IVF patients, so our target audience today is women between 40 to 42, and the possibility of having euploid embryos between their blastocysts is just 30%. And if we have the patients over 42 years old, the probability of having euploid embryos is just 15%. So that's why we are understanding how uh, different there is a statistical data. And in average, we are talking about the chances for women over 40 years old to have pregnancy in a range between 3 to 10% using their own oocytes. And if we are talking about the egg donation cycles, we have just by first embryo transfer the statistical result of about 60-64%, and the cumulative is of course much higher, and it goes up to 90%. So the factors of the ovarian reserve, the main and very important one is the IMH, which shows us the potential of the ovaries to produce the own oocytes, but also we need to remember about the age factor and the quality of the oocytes, and then the quality of the potential embryos. So even if we are talking about so-called combined cycle and the possibility of using the last chance for those who are willing to try that last chance. So the recommendation would be, if we are getting some oocytes from the patient, to provide the pre-implantation genetic screening of the embryos. This is the test which shows us the range of the genetic abnormalities in the embryos. We can also recommend this test to be done for the egg donation cycles, but not obviously, but definitely for those cycles where we are using the own oocytes for the treatment. So while we are getting the oocytes, fertilizing them, creating the embryos, on day 3 we are doing the laser hatching with the further biopsy of the blastocyst on day 5, 6, and the biopsied material is sent to the genetic laboratory, and in few weeks we are getting the results, and only euploid embryos will be transferred into the uterus of the further of the patient and further mother who is going to carry the pregnancy, and this increases the chances of the implantation. For the PGS tested embryos, we have implantation rate of about 71%. So this also gives us the probability and the possibility to increase the treatment success rate significantly. We are able to analyze by the PGS the genetic status of the embryos, including all the chromosomes and also the sex chromosomes. But what is playing the crucial role for the success? Of course, this is the of the embryo, and we talked already about the impact of the oocytes, of the own oocytes and the donor oocytes for the quality of the embryo. Male factor is also playing very important role, and we have the different screening regimes, and we also providing mostly we are performing ICSI method of the fertilization, and we are providing additional screenings if we have some history of the not the best quality of the embryos created before, as the DNA fragmentation, as a FISH method, as the deletion of Y chromosome, etc. But also the endometrium is playing very important role, because this is the fact of the implantation which should take place, and there are many predictive factors which are very important. We will be talking about this a little bit further in our next slides. But this is very simple question, and this is very simple and the main parameters, the embryos and the endometrium. And we know from our practice that we also should take care about the results of the thyroid glands and the level of thyroid hormones, about the presence or absence, the hyper or uh, hyperthyroidism, of Hashimoto syndrome, of the other infections or the immune diseases, of the window of implantation for the embryos, etc. So if we are talking about the endometrium and the pathologies of the endometrium, while preparing the patients and while getting the initial exams of each and every patient, we are checking the uterus very carefully, because the presence of the polyps or the hyperplasia or synechi or the very thin endometrium, it should be treated before. Because even while creating the high quality blastocyst with the usage of the donor materials and with the screening of the aneuploid abnormalities, if we are going to transfer those in the not well prepared uterus, we are not going to have the good success. What is the implantation? Implantation is also very important piece of the IVF treatment, and we know that usually we should implant the embryos synchronically with the period of the progesterone supplementation, and we are checking very carefully the stimulation protocols for each and every patient, the timing of the start of the progesterone and the longitude of the days according to the protocol, how long the patient is taking these. But also, before we are providing the biopsy for some patients, we are analyzing the medical history. We are providing, or we could provide, the biopsy of the endometrium in order to get result of the histological evaluation and make sure that the histologically endometrium is responding well and it should implant the embryo. But also we are doing the screening for so-called window of implantation, because we know that for some women, and this is not a huge category, but about 10%, the window of implantation is moved into the few days earlier or few days after, according to the synchronically taking progesterone and the growing of the embryos. So for this, we are doing several biopsies during the previous IVF cycle and checking the growth of the pinopodia. These are the special cells which are in the normal window of the implantation. They are growing on day 6 and they are mature and they are big and they are looking great and they are helpful for the embryos to implant. But for some women, we see after the results of the histological evaluation of the endometrium that those pinopodias are growing only on day 8 or 9, meaning that we need to transfer the embryos, which are day 5 or day 6, which are blastocysts, not on day 6, because then the endometrium is not ready yet, but we need to transfer these a little bit further for the successful implantation. So also, if we are talking about the immune treatment, this is more related to those patients who had already many IVF attempts with the good quality of the embryos, with the good thickness and structure of the endometrium, with so-called unexplained infertility. But suddenly the results are negative all the times, meaning that some countries, because of their law or because of the possibility or not being able to have immune treatment registered in their country, they are just not including those screening tests into the initial screening regimen for the patients. Meaning that such very common disease as Hashimoto syndrome, having high level of the antibodies to the thyroid gland, which are also playing or having an impact while we are transferring the embryo, which is potentially 50% foreign for our body or for the body of our patient. So the Inca cells, which are also are evaluated according to the response of the immune system, they are just coming into the uterus and destroying the embryo even before the implantation. So for some women, we could see a little bit elevated RCG level after we've got embryo transfer, and we are getting the result not 0.5 or 1.3, but we are getting like 10, 5, 6, 10, 20, etc. So meaning that there are the Inca cells, some special cells which are um, playing uh, against the embryo and getting destroyed it even before the implantation. So in order to have the tests done, we are performing the immune test, or we are recommending this to be done for many of our patients, and based on this, we are performing also the treatment of immune diseases. And it increases the chances significantly as well. So the main focus for us is on equality, and not only on equality of embryology laboratory, which is the highest here, and we really are proud of the result getting in the lab, but also in quality of the analyzing the medical history, of the analyzing the previous attempts, of the analyzing even the attempts which have been taking place in our clinic before, if some uh, was before. So the focus is on equality, and then mm, we are getting the results which are really high. So the treatment options for women over 40. Some of the patients which are coming, so while I started from the possibility of using own oocytes, are still trying to get the last chance. Uh, and this is mostly the category of those who just started to plan their family. So they never been using IVF before, and they have no experience, and they are willing, even if they are hearing about 3 to 10%, they are willing to try. So what we are and how we are performing the combined IVF, we are performing the stimulation. Sometimes it's a natural cycle, sometimes it's a mild stimulation, sometimes it's a regular stimulation for the patient by prescribing the gonadotropins in order to grow the follicles in their ovaries, and then synchronically we are starting the stimulation of the donor in case this is a fresh IVF cycle for the donor, or we are warming the vitrified oocytes on a day of the collection of the patient. And then we are fertilizing retrieved oocytes from the patient and the donor oocytes at the same day, growing them in the different dishes. And if we are getting the results um, uh, as a good embryos from the patient, and for many cases of those, we are performing also the PGS screening, deciding on the decision of the patient. So we are transferring the embryos, and we always decide which embryos should we transfer according to the preferences of the patient. By performing this cycle, we are having 100% of the embryo transfer for all of our patients, because if we are not having high quality, good quality embryos from own oocytes, we are having them for sure from the donor oocytes. Or we have more embryos to performing PGS, and if likely we are getting diploid embryos from the patients, of course, this is preference number one. For those who already tried or who has decided according to their IMH level and their age, or according to the multiple number of the failed attempts using their own oocytes before, we are providing programs with the fresh or vitrified donor oocytes, and the number of our donors is huge, and we are also working as a recruit clinic. So we are having a separate department who is working in order to get the contacts with ladies who are going to be a donor, who is responsible also for their screening and the documents which they are signing, and for them to understand the responsibility for being a donor. We have our own database of the egg donors, and we have all of their results, and we are analyzing always the previous outcomes. So that's why we are selecting only the best donors for our patients. And we might stimulate, like the database includes the donor for the fresh stimulation cycles, and also we have a bank of the vitrified donor oocytes, which now is counting over 5,000 donor oocytes which are already vitrified and immediately available for the patients. And I have also to notice that by law there is no age limit for the fertility treatment in Ukraine, but we have our ethic committee which puts the level of 54, which is the upper level in the world regulated, that as an factor that women over 54 are not potentially being treated in Ukraine. But officially, there is no limit, so we are treating even the patients of the age over 40 and up to 54. There is also a question how to choose the right IVF clinic for starting treatment. So I would like to present you some recommendations which potentially could be useful in order to select the best clinic with the highest potential for getting pregnant very, very soon, or in a good hands, how we call this. So the years of experience on the field of the reproductive medicine, the clinic must be a partner of the big health network, or being having the possibility to exchange the experience with the different scientific groups or in the conferences, etc. It should have the high success rates, the presence of the international certificates, which shows that the process are well regulated, that the team is knowing what they are doing all the time and on every step of the communication with the patient, and also during every step of the treatment. The availability of the proficient doctors, fertility specialists, embryologists, and the coordinators, high level of the embryology laboratory, the availability to undergo all the necessary medical examination at the same clinic, which is also very important. So if you are having the possibility to have the screening done in 1-2 days and have all the results in one place in order for the doctor to analyze and understand the full picture. So this is the great experience. The possibility of obtaining a leave and absence letter for the entire period of treatment, the patient references, which are also important, and the pricing policy, which is not the most important, but it's also useful to be if this is flexible. All this you can get in our clinics for sure. And we are the lead IVF clinic in the heart of Europe. We are the part of the Medicover group. Medicover now has 16 IVF clinics in the whole group, and they are located in the UK, in Poland, in India, in Ukraine, and we're expanding the numbers really significantly. And we are located in the western Ukraine. It's a city of Lviv, close to the Polish border. We quite easy, acceptable by the planes, and we are arranging all the accommodation services for our patients. Regarding the egg donation and the donors, as I have mentioned for you before, there is fresh and frozen egg donors. For now, it's more than 500 egg donors totally in database. They are Caucasian, but also African and Asian phenotypes available. The donors are anonymous and also non-anonymous. It is also allowed by law. All the genetic screening is we are providing in our clinic, but also we are keeping the DNA in order. If the patient like us to do any kind of the additional genetic testing, it is also available. There is a free donor matching, and you can visit our catalog with the 7 days of the registration, with the prolongation as well. You are able to get any additional information about donors. If we are performing one-per-one donation cycle, there is no egg sharing, and we are promising 12 mature oocytes from one egg donation cycle. And of course, the guarantee of the embryo transfer with the blastocyst. And there is no waiting list according to the number of the potential donors we may use. The online catalog you may visit from our website. You can see the pictures and the phenotypical signs. You can select according to the phenotypical signs, and the results of the IVF treatment with the fresh egg donation is 64 per first attempt, 86 per second, and 97 in case we are performing 3 and more attempts by using the embryos created from one initial egg donation cycle. While we are getting this, because we are analyzing the history, we are doing additional screening, we are understanding what could be also playing the role except of the factor that we need to use the donor oocytes. This is, as I mentioned, the biopsy of the endometrium, the histology of the endometrium, the window of implantation, the immune screening or the antibody screening, and many, many others. Also, we are practicing the personal support. So each patient would have a medical coordinator who will be available during 7 days a week, 24 hours, and every day. And we are also talking different languages. Of course, English is the most active used, but also we have German, French, Chinese, if needed. And our best practice, this is that we are doing everything with love, and we are recommending to come to us if you had the experience being treated before, or you had no experience being treated before, or you are looking for really the best place for the easy, successful, and very positive experience your IVF treatment. I tried to be very short because I was said that probably you will have some questions and we will have some additional time for that. As I see now, I could use additional 10 minutes, but we may start from the questions right now, and I will be able to explain more deeply those which are the most important for you. So, Dorothy,
Dr. Uljana,
everything from my side.
If you would like, you can have additional 5 minutes, or shall we proceed with questions?
Yeah, I think we can start from the questions, and I will be just, answering more, not with being so fast, because I had no possibility to try how much time it will take me for all of the slides. So I see now 33 minutes. So I think the good practice will be to start answering the questions, and then we will be able to make this more deeply and with the not with the so fast, speed.
Okay. We have plenty of questions. Our first question is, how do you deal with hydrosalpinx, fluid in the tube, and the ability to affect implantation?
Sorry, I do not hear you really very well. How we are dealing with what?
The question is also in our chat section. How do you deal with hydrosalpinx, fluid in the tube, and the ability to affect implantation?
Yeah. So the hydrosalpinx are really impacting the health status of our pelvis, of the patient's pelvis, and we believe that they should be laparoscopically taken out from the body, because they are not playing, like the tubes are not playing any role for the implantation in case we are doing IVF, but by the presence of the hydrosalpinx, we are keeping the influence in our pelvis, and also the changes with the immune factors and the influencing factors on a blood level, on the cell level. So for the better implantation, and also the all our pelvis organs, they are moving all the time. And if the tubes are not blocked, we are not able to tell that they are blocked for sure, that they are not connected with the cavity of the uterus. So we are not going to transfer embryos into the uterus and the hydrosalpinx are there. So the best recommendation is to have a laparoscopy to remove the hydrosalpinx and to prepare yourself for the embryo transfer.
Okay, thank you very much. We have a second question from Louisa. Would rheumatoid arthritis have any impact on success in pregnancy, as it is autoimmune disease?
Yeah, the rheumatoid arthritis is not something what we are calling as the main factor of playing the negative role, but we are covering, like, these are also the category of the patients which are needed additional immune investigation, and I would say in 85%, even 90% of those, we are finding the additional immune suppression or the let's say, non-healthy activity of the immune system. So we are performing the immune treatment for those patients, but not for rheumatoid arthritis itself, but for the results of the additional investigation, which are quite often also are not fine.
Okay, thank you. Dr. Uljana, we have another question. Are you able to read the question from the chat? The next question is about asthma. Can you read it to our viewers, please?
About the patient of the 42 years old?
No, this one, the last one. The question by a donation spend. Would being on medication for asthma impact getting pregnant?
Yes, I see. So these are the somatic status. I haven't mentioned about this during my webinar, but the somatic status of the patients is really very important as well. So for any kind of the additional somatic or chronic diseases, we should be informed. And there is a list, and for some cases, for very specific cases, the pregnancy even is not allowed. So asthma is not there, but we don't know which level of the asthma or how intensive it is, and if the treating physician is allowing for the patient to have the IVF treatment and carrying the pregnancy, so then we are able to perform the treatment, and we are able also, together with the treatment physician or by the recommendation of our doctors, to select those medications which could be used for the asthma treatment as well. And we had some patients before and we treated them very well. But it all depends on and very much involved here should be the communication between the IVF doctor and the treating physician of the patient.
Thank you. Question number 4. Dr. Uljana, can you read the question? Question number 4.
Yes. So the question is, I had a natural pregnancy at 39 and live 3 IUIs at 8:43 and second IVF resulting in the pregnancy, but a miscarriage followed at 10 weeks. Would it be worth trying IVF with my own eggs before trying with donor eggs? So potentially it's a grade. So we are telling that there is a statistics of 3 to 10% for the pregnancy and the live births for the patients over 40, but potentially the miscarriage really happened due to the quality of the embryo. So meaning that we are talking about the euploid embryo which has been implanted and grown for some period of time but was not really potential to be a healthy delivered baby. So we are talking now about the need potential need of the PGS testing, just in order to understand that we are getting euploid embryos and there are the chances for the implantation and the live birth are the highest possible, and for the miscarriage they are really very low, and this will not happen because of the embryo quality. So for this case, if the response is fine and if we are having the possibility to get some oocytes still, and the lady is willing to try again, so there is no medical contraindications not to try, but we need to be focused on the statistics, and we need to be to realize what really the chances are, and maybe the next step would be the egg donation after trying again with the IVF, or maybe we should do the combined with the PGS in order to understand what is the potential, etc. So it's really, we need to have the IMH here, we need to have the antral follicle count, the number of the oocytes which are responding and growing for in answer for the gonadotropins stimulation, etc.
Thank you. Question number 5. Could you read the question?
Yeah. So I fell pregnant naturally in May but miscarried. I have done IVF but didn't get many eggs. I responded better to Clomid and low dosage FSH than high dosage FSH plus LH. My fertilization rate is 100% to all eggs recovered. What protocol would you suggest? Should I do IUI or IVF? I have no tube or sperm issues. I do not see the age of the patient actually here, so it's not easy to also to there is not a full clinical picture, but yes, it is true that some of women, because of the, if you are having very low IMH and low antral follicle count, the natural stimulation or the Clomid or the Letromara stimulation with the low dosage FSH is really useful. But the question is that while doing this stimulation, we are getting just few oocytes. And the chances of those oocytes, if we are getting them to be mature, to be well fertilized, and to get into the high quality embryo, at least on day 3. But we are more likely would like to work with the blastocyst, because longer we are cultivating them, more information we have about the potential of the embryos, and if they are really not getting into the blastocyst stage, so the possibility for them to be implanted is very low. It's a debate issue, I know, and we are debating about this a lot on our scientific meetings, but generally the natural stimulation is fine for this case. It's good that the fertilization rate is 100%. So the question is what is the age, how many oocytes we are producing, and what is the quality of the embryo transferred. So we could continue trying this low dosage stimulation and the treatment regimen as it is, but also thinking about like analyzing previous attempts, analyzing and more plain taking about the embryological data and the quality of the embryos. And the IVF would be better for this case because while doing IUI, we are just we are helping for the oocyte sperm to meet, but we do not check if really the fertilization occurred, what was the quality of the fertilized embryo, if there was an embryo for sure, and how it's developed, and if there is a potential for implantation or not. So IVF is really more recommended here.
Okay, question number 6.
Question number 6. Should I try IVF with my own eggs at the age of 46, or I should start with donor eggs? You know that we even have no statistical data for the own stimulation for those patients. Like usually the older patients which are included into the analysis are women in the age 42, sometimes 44. Over 45, this is the age while we are not recommending even trying the stimulation with the own eggs, and start the treatment with the donor immediately, like to increase the chances and to having the best chances and the results.
Okay, question number 7.
I have had 2 failed donor egg cycles at a clinic in Spain. Now I am at a crossroads and don't know whether to choose another clinic or try a new donor at the same clinic. I was not offering any genetic screening. Um, so as we said that the question is if they were the embryos on day 3 or the embryos on day 5. What was quality? Because we also have the grading of the embryos, which is the advanced blastocyst category A or B or C, because the morphokinetics is also playing a very important role. There is also no information regarding the endometrium thickness and the absence of the immune disease of the patients and the full screening of the patient herself. So that's why I really don't know what to advise here. If you could contact us and send us more information about the not only about the egg donation cycle itself, but also about the medical conditions of the patients, patient in that case, so it would be great. So then we would be able to advise something. And regarding the genetic screening, so the data says that 30% of the embryos could be potentially aneuploid, even for the donor cycle. But having 2 embryo transfer with even with transferring 1 embryo or transferring even 2 embryos, so it's too much. Usually, we should get pregnant in first or maximum second attempt with the egg donation treatment.
Okay, thank you. Question number 8.
I had 2 failed IVFs with donor eggs. What should I do? You should definitely continue your way into parenthood or the motherhood. Again, the question as it was to the question number 7. If you are screened really deeply, if you know everything about yourself, if you did the investigation of your endometrium and your immune system and screening of the embryos, it said there are many additional factors, as we already know, which are playing a very important role. So the question is to get the medical history, to get the story, what has been done, and what is
Hello, Dr. Uljana. I think we can't hear you.
Yeah.
Yes,
Yep.
okay, we can hear you now. It's okay. Next question. Question number 9.
Yeah, that's it.
Okay, question number 9, please.
Question number 9. I see. I recently lost my due to the borderline tumor, but I still have my uterus. What impact does this have on the treatment prior to IVF? Um, so this is really interesting question, and we are also working. I hasn't mentioned this here, but we are working with the patients who are going to be treated for the different kind of tumors, and we are performing cryopreservation of the ovarian tissue before the any kind of multi if if the need of the multi chemotherapy is needed, or the radiation for the pelvis is needed. But this, if this is the tumor of the ovaries, it's not usually the practice we are using. But the question is how long ago the treatment has been performed, because usually after 2 years of period not seeing any recovery of the tumor, usually the oncologist is able to send the confirmation that the treatment for the IVF is already could take place. So after having this conclusion from the treating physician oncologist, we are able to accept this patient for the IVF. And in that case, we would recommend IVF with the egg donation, and those patients are getting pregnant. They are not different from those which have different reasons for using IVF with donor eggs or so. Um, the impact of the hormonal treatment prior to IVF, in case we are going to do the embryo transfer of the embryos created from the egg donor and the sperm of the partner, the preparation be also very minimal, just with a low dosage of the estrogens or even in cycle. We just need to follow the natural cycle and get, even without ovaries, like we have ovarian cycle and the uterine cycle. So it can be predictable, or we can recommend very low dosage hormonal replacement therapy and perform the transfer. But question is, when can we start, and how long ago in that case was the treatment for the tumor, and if the oncologist is already able to provide us with their conclusion regarding the further IVF.
Thank you. Question number 10.
Do you have frozen oocytes? What is your opinion about them with respect to the risk versus ease of timing for combined cycle and travel? So yes, we do have the frozen oocytes. We are keeping the bank of the vitrified donor oocytes. 2008 we have that bank, and we are keeping constantly about 5,000 oocytes and more. You can select those in our donor online database by putting the mark vitrified oocytes. There are two marks, fresh and vitrified. You can contact the coordinators and they will help to understand how the database is working. If we are talking about the risks for using vitrified oocytes or the statistical results with them, so there is no statistically significant difference at all. The issue is more related that for the vitrified cycles, we are usually recommending, or we are performing those cycles with the limited number of the oocytes. More oftenly, or like the basic package, including just 8 oocytes. So if we are talking about the statistical data with using 8 vitrified oocytes and compare to at least 12 mature the fresh cycle, so the outcome in order with embryos is different, and the selection of the embryos is different, and the cumulative pregnancy rate is different as well. The statistical data, however, says that for cycles with the vitrified oocyte rate for 59%, comparing to 64 with the fresh oocytes. But it also, I believe that the crucial role here is the initial number of the oocytes per cycle and the difference here, but not the difference in the statistical data. It is. And for the combined cycle, we can use either fresh donor oocytes together with the retrieved oocytes from the patient as the vitrified oocytes. Even for combined, vitrified are more recommended because there is no need in the synchronization, as the older patients sometimes are responding not as we are expecting. So let's say the average longitude of the stimulation cycle should be 12 days. But the patients with the low ovarian reserve are usually have shorter stimulations because the number of the follicles which are recruiting is also small. So meaning that sometimes we could have the stimulation of 8 and 9 days and the donor is not ready until that time. So for those cases, really vitrified oocytes are beneficial because we may warm them in any day. Uh, so this is a good option.
Thank you very much. We have 7 more questions. I hope we can answer them all. Question 11. Question 11.
Yeah, let's try.
Let's start.
So I am 42 with very diminished ovarian reserve. What are my chances of success with own eggs for PGS for gender selection? Statistically, we are calculating for women over 40 because of the level of the maturation level of the oocytes is lower, fertilization level is lower, etc. So in average, we would need 6 to 8 fresh oocytes from the patient in order to create one blastocyst, being able to biopsy this blastocyst and perform the genetic testing. Meaning, if compared to the egg donation, we would need in average 4 oocytes in order to have blastocyst. So for older patients, the number of the oocytes needed for one blastocyst is also higher. So, and if we are talking statistically again, if we have very diminished ovarian reserve, meaning that by one stimulation we can provide likely 2-3 oocytes, in order to have at least 6, we need to have statistically 3 stimulations. And then from those 6, we potentially could have one blastocyst, which potentially to be euploid only with the 15% of being normal. So as we said, statistically it's between 3 to 10%, but multiple stimulation cycles would be probably needed here, and with the diminished ovarian reserve, the chances are really, really low. But I never said no to anybody if this is the reasonable question. So I think this question is really reasonable to try at least one stimulation to see what we are going to get from there, and then to see how should we proceed further.
Thank you. We have question number 12.
What is the shortest time I would have to stay in your country if I were to use donor eggs? So this is a very practical question. Thank you very much. Usually we are inviting patients for the initial meeting in the clinic, meeting with the doctors and getting investigations done. But we can skip this in case the patient has all the results done in their home country. And then if the partner is going to come and provide the sample, the sperm sample, which is going to be frozen and then used for the fertilization of the retrieved oocytes, so the patient herself should come only for 3 days for the embryo transfer itself. And these dates are always predictable because we are prescribing the stimulation protocols. Of course, the ultrasound scans would be required to be done in the home country and the results to be sent to us immediately, and we will correct the protocol. We will confirm the date of the embryo transfer, but the minimum timing is 3-4 days and just once. But the optimal is to come for the initial visit to get all well prepared, the medical papers signed, the medical history evaluated, all the additional tests to be performed, which probably are not performed in the home country, and then come again for in that visit the partner could freeze and leave the sperm, and then the lady could come for the embryo transfer 1.5 to 2 months later.
Question 13.
13. What is the statistics success rate for fresh eggs versus frozen eggs in your clinics? So this is the data for the first half of 2017, and the statistical data is 64 for the fresh for the cycles with the fresh donor oocytes for one embryo transfer, getting the clinical pregnancy, meaning positive heartbeat in the 6 weeks. And the frozen oocytes, the vitrified oocytes, which has been used, we have the clinical pregnancy rate 59 for the same period of time.
Thank you. Question number 14. About diabetes.
Can you do IVF if you have diabetes? What is control? Depending what type of the diabetes the patient has, and what would be direction from the treating doctor. If the treating, like as I said before, any somatic status or any somatic or chronic diseases should be discussed together with the IVF doctor and the treating physician of the patient, and only with the latter confirmation from the treating physician that this patient potentially can perform IVF, can successfully carry the pregnancy. Only together we are creating the supportive medical treatment plan, and only after this confirmation we are performing the treatment itself.
Thank you. Question number 15. We still have some time.
You mentioned that you have donors from Africa and China as well. Do you also provide sperm donation as well? Yes. Yes, for both questions. We have donors. We are communicating and cooperating with the agencies in South Africa, in Asia, China, in the different parts of the world, because our patients are coming from the whole world. So we need to have those options available. Mostly those donors are so-called traveling donors. So we do not have them available immediately in Ukraine, but we are, by the communication with the agencies, we are planning the treatment cycles for them, and they are coming for the fresh stimulation and all the IVF treatment for them, like not the whole IVF treatment, but they are starting the stimulation in their home country, and they are coming for the egg collection, as well as the patients are coming. So the final step of the IVF treatment is taking place in our clinic, and we also do a sperm donation as well, as local Ukrainian, as an international as well.
Okay, question 16.
16. I am 47 years old from the UK and want to try donor eggs. Do I stand a chance? Yes. I should mention, or probably I just forgot to mention this, that even if the age is a negative predictor, but while we are getting high quality embryos or euploid embryos, so then the chances for different age categories of the patients are the same. So, meaning that even if you are 47, but you are getting high quality euploid embryos, the percentage of the implantation for you would be the same as for the woman of years old. Again, with the high quality embryos, because the implantation is not playing such a crucial role for the different ages of the patients, because we are able to implant until we are having the menstruations, or even after those, in case we have the hormonal replacement therapy and we are preparing our uterus for being able for the implantation. So with the donor eggs in that age, the chances are really high as 64% with the fresh or 49 with the vitrified eggs. I also see somewhere the question regarding the single women. So if I can answer this, that by law we can accept the single women for the IVF treatment, and there is no regulations regarding this or contraindications. So we can treat either the official couples or the couples which are not officially married but just live together, or the single women for regular IVF treatment or the egg donation treatment.
Okay, or we can go to a few questions. We have about 4 or 5 minutes. Question from question number 17.
Can I do IVF or egg donation procedure without additional tests having Hashimoto and anti-TPO high? Anti-TTG is okay, are okay. Yes, but if the Hashimoto is confirmed and the level of the antibodies to the thyroid gland is high, the additional test for the immune activity is recommended to be done. And usually, for those patients, the INCA level of the cells will be evaluated, or there will be a difference in the T lymphocyte helpers to the T lymphocyte suppressors, which is also the point that we should do the immune treatment for those patients. So yes, this patient could have the IVF or the egg donation procedure, but with the immune treatment, which would increase the chances for the implantation and is really needed for that case.
Question 18.
Do you also have a clinic in the UK? As we are the part of the Medicover group now since 2013, the Medicover themselves, it's a private healthcare provider, the huge provider in the Central and Eastern Europe, but not only Europe already. And there are 3 branches: Medicover Healthcare, Medictics, and the Medicover Fertility. So the Medicover Fertility has a clinic which called Reproductive Health Group in Manchester, and we are in the one group by now. They are also getting vitrified oocytes from Ukraine. We are able to export the oocytes into the UK according all the Asians, And you may have the IVF treatment with the donor vitrified oocytes in the UK, in that clinic in Manchester.
Fantastic. Question 19.
19. If the clinics helps uh, with visa processing, how long does it take for visa to be ready? Yes, we are helping with the process. We are sending the letters that you may present them in the consulate or in the other authority you need to require in order to get a visa. But how long it takes from our side to prepare the documents, it doesn't take long. You just need to have your passport and the dates for the treatment scheduled, and we will send it immediately. But how long does it take from the other side? We don't know, and we have any influences for that. So then you need to find out with your country institution or the consulate or the other institution.
Dr. Uljana, we have two more questions. Can you answer two more and we will be finishing?
Yeah, okay, sure.
Okay, so question number 20. It's a long question.
Okay, I have a fibroid, but was told by several doctors that fibroid was not causing a problem, but had two failed IVF with donor eggs. At day 5, blastocyst perfect grade. One in UK, one in Cyprus. Now we have decided to have donor egg and sperm. Could you advise us if that okay? I am on folic acid, aspirin, low dosage, and cycloprogenol to regulate the cycle. Will intralipid 20% on transfer day? There are also other medications involved on treatment. How many embryos should we transfer? Very nice question. So really the fibroids, depending where they are located, they could be a cause of the miscarriage or they couldn't be or shouldn't be. If the doctor said that it shouldn't be a problem, probably really it shouldn't be. If this is not the fibroid which is impacting the endometrium cavity. But two failed IVF attempts without implantation said that there is probably an issue with the implantation, not the issue related to the quality of the embryos, because it was a perfect grade and blastocyst day 5. So you should really analyze your implantation potential, maybe the window of implantation, maybe the IVF treatment you are mentioning here, intralipids. So this is what probably we would recommend as well. But also the endometrium should be investigated more further. We are also recommending the vitamins and the low dosage aspirin and sometimes the prednisolone as well for the patients who are preparing themselves for the treatment cycle. So in that case, IVF treatment, IVIG treatment, I would really recommend. What are the other medications except the dose which you have mentioned above? It's only prednisolone. How many embryos should we transfer? By our practice, we are transferring 1 or 2. We are not able to transferring 3, except the cases with the failed negative multiple cycles before, and multiple are meaning more than 3, or if this is a very, very low quality of the embryos. However, we are doing this really, really very, very, very rare. Mostly we are transferring 2 if the embryos are not screened genetically. But in many cases recently we are transferring just 1 in order to avoid multiple pregnancies, because the potential, the implantation rate is high and the success rate is also high. So for last half a year we had 36% of the twins, which is really really, really high. So we started to think about even transferring more, one embryo per transfer.
Thank you. And our last question, question 21.
Is arterial hypertension a contraindication for IVF with donor X because of the higher preeclampsia risk? No, the arterial hypertension is not a contraindication for IVF. Only in cases of really huge level of the of of the blood pressure, but this all can be treated. And again, we are coming to the somatic status and the chronic diseases, and the preeclampsia risk is also, it could be and it should be treated during the pregnancy care and the control by the physicians during the pregnancy itself. So generally, no, you can be treated, but you should be treated both by the IVF doctor and by your doctor taking care about your hypertension status.
Thank you. Okay, that was supposed to be our last question. Could you answer the last one because Piotr is asking for some clarification on the Hashimoto issue. Can this be that question, please?
Yes, okay. So the Hashimoto anti-TP results are varying from 250 to 1,300, and Hashimoto is confirmed with ultrasound exam. I have had 7 IVF treatments, one with success pregnancy but lost in 8 weeks. Natural abortion due to genetic failure. Can this be due to Hashimoto? And do I need to cure it additionally? Yes, both. Like if the genetic failure is confirmed here, so probably the main issue was the genetic failure. But the such really low success rate for 7 IVF and just 1 implantation probably is connected to the Hashimoto and the level of the antibodies. So the additional treatment and the IVIG treatment would be recommended here, and this would have a great impact for the success. And I need to mention that sometimes we are recommending the IVIG treatment not only once for the implantation on a day of the embryo transfer, and after the initial infusion, it's valid for 28 days. But for some patients with really significant immune issues, we are recommending to do this even until 12 weeks of the pregnancy, and we are having patients who are successfully pregnant, but they are applying again every month at least 3 times until they are reaching the end of the first trimester in order to overcome the issues of the early miscarriages for those cases.
Okay, Sharon has got a question. Question from Sharon.
I had 3 failed
Can you do one more?
IVFs with own eggs, very high IMH, which gives loads of follicles but very little mature eggs. Should I move to donor eggs? No, probably not. But the question is, how old is Sharon? But potentially, if there is a high IMH level, which this is just the question of the selecting of the best stimulation protocol. We can do for such cases. The recommended protocol would be a step-up protocol, starting from a little bit lower dosage of the FSH or the stimulation drugs in the beginning, not recruit so many follicles at once, and then increase the dosage in order to giving the potential for those follicles which are already recruited to grow. And then the number of the mature eggs will be much higher. And this is good. Like we like to have a good number of the oocytes. And even if this could be a cycle with if the potential of the ovaries is such high that we could expect the OHSS, the syndrome of the hyperstimulation, we always have a possibility to select the trigger and then to freeze the oocytes or the embryos and transfer them in the next cycle in order not to have the risk of the OHSS, but to have the good number of the oocytes and then the further created embryos. So no egg donation, just the right treatment regimen for Sharon.
Thank you very much. So that was the last question from the attendees. Dr. Uljana, thank you very much for the presentation and the replies to questions. And dear attendees, thank you very much for taking part in our webinar. Thank you for fantastic questions. I hope you learned a lot. The video will be, of course, available on our website to be watched again, and the questions and answers will be also published. You will get a chance to read it again. Thank you very much, Dr. Uljana. Thank you.
Thank you, Dorothy, so much. It was actually my first practice, but I really enjoyed this, and thank you for being so active and for all of those questions. You really helped me to present and to say more, and I believe that those questions and answers have been helpful for many of you. And thank you for all your time, and thank you for being active, for moving, that everyone will get pregnant. Just the question is how long for some of you it will take, and for some of you that it will not be in your next attempt, but for sure you need to move on, you need to move forward, you need to look for the best places, you need to move, you need to try different options, you need to be screened deeply, you need to understand the process together, you and your doctors, and then the result would be really positive and you will be enjoying your parenthood. So good luck for all of you, and thanks again.
Thank you very much for listening to our webinar, and good night to everyone.